Thank you very much. Many thanks to the organizing committee for this kind invitation. Of course, many congratulations for organizing this exceptional meeting. So, let's go straight to the case. 78-year-old male with risk factors, effort angina, CCS class 2 during the last few months. The patient was on medications for hypertension, hyperlipidemia. In terms of anti-anginals, he was on bisoprolol 5 milligrams. His cardiologist referred him for a myocardial perfusion scan, which had shown ischemia of the inferolateral wall of the left ventricle. And based on those findings and considering that the patient was still symptomatic while taking bisoprolol, he was referred to another hospital for having a coronary angiogram. This is his coronary angiogram. You can appreciate a tiny non-dominant right coronary artery, a large dominant circumflex with a tight lesion proximally, a tight stenosis in a large diagonal branch, and here in the cranial views, you may appreciate that the left main has actually a bend. The initial course goes up and then it turns about a 90 degrees bend, and at that point you can appreciate that there is some irregularity. You may call it haziness or lucency or whatever. It seems it's not quite normal. And the doctors who performed this angiogram reported that the left main has a 60 to 70% stenosis, and based on those findings, he was referred for surgery, and he was actually accepted for bypass surgery.
Okay, very nice and quick. Now we have difficult choices, or maybe straightforward. Professor Angouras, patient was sent to you. Are you happy with these pictures? You need something else?
Well, he was not sent to me, but if he,
suppose
I wish he had. Anyway, well, you know that what I always say in the heart and everywhere is that we cannot accept nowadays a cath lab report saying that there is a 60% left main stenosis. This is not acceptable nowadays. In this patient, things are a little, not straightforward because he has severe distal disease also, but not LAD disease. So in this case, whether he has a left main stenosis or not is important. So taking that in mind, we need to proceed and be sure that his left main disease is significant. And to do that, we need an IOS, just to be sure that the MLA is less than what we think it should be, like 6 square millimeters.
Just to add that if there's severe left main stenosis, it's not expressed in the myocardial perfusion scan. What the scan shows is the ischemia from the circumflex lesion. Just to keep this. Dr. Kanakakis.
I think that I have to delineate what is happening in the ostium of left main. This is the main issue for these patients, and the best approach is to do IVUS in order to define how is the MLA, and after that to decide if we go for PCI or Cabbage. I think the most important issue in these patients is to find what is happening in the ostium of the left main.
Kafkas, you agree?
Kostas, could I have some more information about the pressure, blood pressure in cath lab? From the catheter?
I think you're asking whether there was
there's a suspicion that
in the pressure waveform from the tip of the catheter. That's what you imply, I think. What do you mean blood pressure in the catheter? Yeah. I don't have this information. The angiogram was done in another hospital. In the report, there was no comment about that.
But even if there was blood pressure, my feeling is that it wouldn't be reliable because the problem is that the extreme kinking.
Exactly.
And the tip of the catheter is against the wall, you may say. So even with blood pressure drop.
Exactly. Actually, the true ostium seems to be quite normal. The problem, the theoretical problem, is just at the proximal part of the left main. Actually, there is this acute bend, which shows this lucency or haziness there.
I have a question. You think that a CT, a coronary CT, would be useful? Or even if you have the patient in the lab, an aortogram, just to define better how the origin of the left main is?
I think CT could be an option, but I think that interventional investigations such as IVUS would be more informative, I would say.
Yeah.
In terms of the takeoff of the ostium, I believe that from the angiographic views, it's quite clear that the initial part of left main goes up, then there is a bend. I don't think there is any possibility of having a problem with the true ostium. This ambiguous area is just a few millimeters after the ostium, just at the side of this acute bend.
So what we are missing is to calculate the exact surface at that point of the lumen.
Yes.
Okay. But not the first operator, not the interventional cardiologist, and not the surgeon. Up to this point, they didn't proceed to any other step. So let's hear now. Is there any discussion or comment from the audience? Yes, please.
Can I ask a question? If there was no lesion in the left main stem, what would be the approach? Will it involve the left main stem or not? Because it's an ostial lesion you said in the circumflex, correct?
No, I didn't. There's no ostial lesion in the circumflex. I'll go back to the pictures. There's a tight lesion. The ostium of the circumflex is quite normal. Give me 1 second. You see the lesion on the right. I don't have a pointer. Do I have a pointer?
So
it's not an ostial lesion, right?
Angioplasty could be an option, though.
There's no pointer. Excuse me.
Yeah, I was just going to give a brief UK perspective. The UK is a big user of CT now, and there are a number of interventional doctors who will not go into a case almost, unless it's an acute case, without having a CT. And you can imagine if you get high-quality CT with high-quality physiology and all the plaque morphology, presumably you're just going to go in and do the circumflex. You've got a symptomatic patient with a MIBI scan or a perfusion scan suggesting circumflex ischemia, I think you suggested. And then the ambiguity disappears immediately. And so I think that CT, for me, is the future. And I think in elective cases, in the UK, it's almost mandated. We're a bit of a slow to adopt it because of CT capacity. But depressing as it sounds from an interventional cardiologist, I think it is the future. I think people should arrive to the catheter lab with all of this information up front.
So how you could proceed with this? By a CT or by bringing the patient back to an FFR?
The patient, well, it depends. If this was done at a different hospital,
yes,
I would probably do a CT. Why put the patient through another invasive procedure with the risk of left main of wiring something and causing some trouble? I personally would potentially do a CT. Good. Or if you're so sold on the perfusion scan, you just say, do you know what? The man's got symptoms, he's got circumflex disease. When I'm there, I'll assess while I'm treating the circumflex, I'll assess the left main with IVUS first.
Everyone agrees that we don't have enough information, so let's have a quick, there's a question about, Dr. Printzios.
I would like to point out that sometimes interpretation of IVUS images in the ostium of the left main, if there is such a bend, can be challenging if the IVUS catheter is perpendicular. So also it does not rule out spasm due to the catheter.
Okay, let's see now by Dr. Terentes how to assess left main disease before seeing what Professor Aznaouridis did with this case. Dimitri.
Yeah, thank you. I would like also to thank the committee for inviting me in this great seminar. So